We're going to try to be interactive. So if you have any questions during the beginning part, we'll kind of try to hold that off for a little bit. And then when we get to the part where we talk about a case, you guys can definitely use the chat box and we'll try to get to all the questions, and then we can talk more about, I guess, like an ask me anything kind of style if we have enough time. So today we're going to talk about telemedicine. So my name is Erkeda DeRouen. And a little bit about me, we kind of covered it. I am board certified in family medicine and lifestyle medicine, went to Boston University for medical school, went to University of Maryland for residency, Hampton University for undergrad, and now I'm working as an associate medical director at 98.6. And I also, for anyone who's interested in certain, I guess I'm assuming most of you guys are in medicine, I host a podcast called The Prospective Doctor that talks about hot topics in medicine, and we also interview different people from different specialties and things to kind of give you a little more information about what's out there. So our topics of discussion today are the history of telemedicine, the current state of it, and then we'll do a little case. So for those out there who may be wondering, what is telemedicine? So in order to start a discussion on telemedicine, we must first know what it is. There are terms telehealth and telemedicine, and they're often used interchangeably, but there is a difference in the definitions. The term telehealth is now more commonly used as it describes a whole umbrella of different things, and ranging from diagnosis, management, education, and other related fields of healthcare. These include, but are not limited to, dentistry, counseling, physical and occupational therapy, home health, chronic disease monitoring, disaster management, and other consumer and professional education. Then there is telemedicine. So telemedicine is often still used when referring to traditional clinical diagnoses and monitoring that's delivered remotely utilizing technology. So that's kind of what we'll be talking about today. So a little bit about it. It can be kind of provided in various modalities, such as live video like conferencing, kind of like using Zoom or Skype or something to see patients and interact as if they were in the room. Remote patient monitoring. This can be patient and health medical data that's shared in real time for monitoring for people. Think of people who are like in the ICU and you're reading like their EKG and stuff on those machines, or if you are a physician and you are in a remote location and trying to look at all the other data that's coming in from different people's vitals and stuff like that. Asynchronously, so this is the patient medical record of date being submitted electronically and outside of real time. So you can think of sometimes when you go on a portal and kind of talk to your doctor and ask a question and go through that back and forth. You're not there together, but you're going back and forth. And mobilely, so lots of mobile applications are coming out to support healthcare. So I'm going to have you guys take a peek at this video.
Elroy, why aren't you ready for school? I don't feel good, Mom. I think I'm coming down with Venus virus. Venus virus, Henry. Last week you said it was martial arts. Space calculus test. I tell you, I'm sick. Oh, this is it. It's going black. Where's a pencil? I've got to make up my will. All right, hold on. Just hold on. I'll call the doctor. Calling Dr. Racy. Dr. Ken Racy.
Yes, Mrs. Jetson. Somebody got pain in the tummy tub.
It's Elroy, Doctor. I think it's the Venus virus this time.
Venus virus? Oh, that can be catching. Oh, Elroy, this is your dedicated physician speaking. Stick out your tongue. Oh, my.
Well, what do you see, Doctor?
2 dozen gumdrops, a strawberry sandwich, half a pizza.
Elroy, for breakfast? Well, you see, I thought it was a nice day in Earth.
Yes, well, it pains me to tell you, but there's only one known cure.
What's that?
A full day of school. You're fine.
Oh, boy. Elroy. Thank you, Dr. Racy. Sorry to call you needlessly.
Think nothing of it, ma'am. It's my duty as the patient's #1 dedicated physician. Which reminds me, one house call, the usual fee. Don't worry, our bill tomorrow morning will be fine. Happy medicine.
Well, Elroy, you just spent your father's raise.
So you see, they knew all the way back in 1962 Well, actually a little bit before then. So we can look at this little timeline of telemedicine over time and look kind of at where we started. Back in 1948, the first radiologic images were sent via telephone across 24 miles in Pennsylvania. In 1959, the University of Nebraska had their first telephone, kind of like fax information of medical records. In the 1960s, Nebraska Psychiatry Institute broadcasted live TV consultations where psychiatrists could interact with their patients even though they weren't in the same room. Like, how innovative was that? In 1961, NASA did some testing on remote animal monitoring in space, which has kind of paved the way for the remote monitoring that we do today. In the 1990s, the internet was born, which paved the way for a lot of ways that we are connected in the comfort of our own home, but also paved the way for telemedicine visits. In 1993, the American Telemedicine Association was founded, and this nonprofit organization is designed to promote and expand telehealth technology as a way of increasing access to patient care. And in the 2010s, there was more regulatory bodies that are coming out to invest and expand in the services. And in 2020, of course, the pandemic has pushed telemedicine into the forefront. So there are various ways that patients typically perceive patient care in the traditional brick and mortar way. So of course, there's outpatient medicine where you have your primary care and your specialist office, as well as urgent care facilities. Your emergency departments, which are well suited for emergencies, although they're sometimes overutilized in the US for many reasons. But an important factor is that we don't have a universal health care where a significant amount of our patients can be managed appropriately. And there's inpatient care where patients are managed when they need a higher level of care in the hospital, or they need some surgical interventions. Then we get to telemedicine. As we can see here, this is a very limited list of a lot of different companies, but you can tell by just this that the market is saturated, and these don't even include the places that are affiliated with hospital-affiliated organizations. So with all of that popping up, that didn't pop up last year in 2020, so we expected a boom eventually, but then we got COVID. So things spread a little more quickly, and we're just going to take a view as to how the spread of COVID started here in this one little area in China and expanded across the globe. So we'll take a little look at how virology in action works. And as we see, it's just getting bigger and bigger, and it's going to eventually get to where we are today. So this I pulled from actually today, the Johns Hopkins dashboard, where as of 12:30 p.m., we had over 112 million global cases, over 2.5 million deaths. And as we all know, most of them are in the US. We're leading in a way that we don't want to lead. So telemedicine is kind of needed. But so we know that when the virus started to spread, we were faced with a lot of new problems. So there was decreased PPE. There were issues with facilities needing to close for various reasons, like needing childcare, like being sick and needing to quarantine. So we needed some other ways in order to help get people the care that they need. So telemedicine became a viable solution. It had a mission. The mission was to triage and kind of see which patients needed to present for an in-person exam or assessment versus being safely managed at home. They were able to intercept unnecessary visits and expand access, because there is a fact that 9% of doctors care for 20% of our US population in rural areas. So there are a lot of people who just don't have access to care. So this may have given them some option, although there are also some healthcare disparities with that in terms of access to phones, electricity, and all of the technology that's needed, computers. So these are some scenarios in which telemedicine is being used during the pandemic. So if someone had some respiratory symptoms and they were told not to go to the emergency room, this was happening especially a lot in the early pandemic where things were a little overloaded in the emergency room, so they wanted to triage. This patient didn't have any symptoms, but they had a positive contact. So they are able to figure out how to get quarantine restrictions and isolation rules without being seen in person. People who had chronic health conditions like diabetes and hypertension and COPD and all of these things that still need care, but may have not had access because maybe their provider wasn't there, or maybe their provider schedule is different, or maybe they're seeing someone from online, or maybe the patient is afraid to go in. Sometimes like is used because, like I said, the provider is not sick necessarily, but they've needed to be quarantined. So they can still see patients and not clear out their whole panel for the week, which could be hundreds of patients, but see them in a different manner. And then also when there are ways where there is decreased specialists in different places like remote areas or rural areas. So sometimes when a patient is hospitalized, we can utilize technology to say have a infectious disease doctor rotate in the ICU without actually being there. So as we've seen, telemedicine is popular. It's popular for a reason, and it's definitely helping the workforce take care of patients. So now we're going to take a look at a particular case in which a patient has come to a telemedicine organization online. So we have our patient, Cardi. She is a 28-year-old female with no significant past medical history who's logging onto a popular telemedicine site, and she has a concern of a cough. This is the part where I want us to kind of interact, and you can make suggestions in the chat, but what questions would you want to ask her?
I think everyone's still recovering from Cardi.
To make it a little identify with the patient.
Everyone loves it. They're saying, how long has this been going on? Do you have fevers or chills? Positive contact, medical history. What kind of cough? Is it dry? Is it wet?
Those are all great questions. And I'll have a few answers for you. So cough is such a broad topic that I kind of set us up for opportunities for discussion, because there are so many different things that you can think about when you think about a cough. So to answer some of the key questions that you asked, you would like to know kind of what kind of cough. Is it dry or is it wet? Because that can help you kind of figure out certain things, like certain dry coughs, like when did it start? Like, is this something that is new and could be something that's viral? Or is this something that has kind of been brewing for a while? Sometimes when people have had coughs for a few weeks, you may say, okay, it's viral. And then if it's viral, you might want to think about after the viral cough, they have post-viral illness, which can last 4 to 6 weeks. If some coughs become productive, you want to think about if they have like pneumonia or something like that, or what's going on, or is there some kind of underlying autoimmune disorder or interstitial lung disease, which may be a little more dry. So kind of figuring out wet versus dry is a very important thing that can increase your differential widely. And then also figuring out the timing also can help you kind of tick off certain things. So a little more about her symptoms. So her cough is non-productive. She has been noticing some shortness of breath. She has a little bit of chest pain, some pressure. It's about a 7 out of 10. She doesn't have a fever, and she's been having some muscle aches. Any additional questions that you would like to ask her?
So we're waiting for some responses to come in.
It's okay.
So again, someone asked if she has any fever, the onset of this, any contact, history of asthma potentially, if she's traveled anywhere recently, loss of taste or smell.
These are all great questions.
Yeah.
Someone's asking about blood pressure and there was something else that was interesting. I have no idea what it was.
Some people were saying family history and her social history. So if she's a smoker or in contact with anyone who smokes.
So those are all great questions. So I'm going to just answer a few of those, and then we'll see if there are any more that come from that. So her cough was non-productive. She's been having some shortness of breath. She is not a smoker. She's never had anything like this before. She does not have a fever. Someone asked if she had any sick contacts. She does not have any sick contacts that she knows about. She has not traveled recently. Yeah, I think that's about it. Trying to, I guess, think through some of the reasons why you guys would be asking that. Would someone like to tell me why does it matter if she's traveled recently?
So a lot of people are talking about blood clots and PEs.
Mm-hmm.
Also, just like in the case of COVID, for tracing purposes, and if she was in a certain area where it was very prevalent, tuberculosis potentially.
Mm-hmm. Those are very great reasons. And then someone else asked about family history. What types of family history were you guys asking about?
We did see some people asking about any history of like heart attack or heart disease, asthma, COPD.
Mm-hmm. Those are great questions too. The family history of a heart attack is important. She is having chest pain. One thing that would make that lower on the differential is because she's 28, so that's less likely. She is a non-smoker. There are some things that can kind of mimic heart attacks. In younger people, you would think about, is she smoking marijuana? Sometimes it can be laced with certain things that can cause issues. If she has done cocaine, sometimes they cause coronary vasospasms that can mimic a heart attack, especially if she is using cocaine and say had a history of hypertension. If she was getting a medication in the class of a beta blocker, that's a big no-no. That can cause some vasospasms. Other things you might want to think about, since you guys were asking about, you guys said the contact tracing for COVID, of course, during these times, that is very important. Or to see, even if she had a risk of being around people, since she said she had no exposures, like what level of contacts has she had? Someone mentioned tuberculosis. That is also very important. There are outbreaks in certain areas. Certain people are at higher risk, like if they're immunosuppressed, if they have HIV, if they were recently incarcerated. So those are some really good things to think about. And you guys are kind of getting at the way to structure the way you ask questions. So I'm just going to go to this next slide, which kind of helps us kind of figure out some of the things we need to ask. So one thing, when you're on your rotations and you're starting to take a medical history, when you're getting the information, they like to do the OPQRST. So figuring out when the onset is. So when did it start? As we kind of hit on earlier, things like acute things versus more chronic things can kind of make a difference, like in terms of where you want to go with the differential. So if it's acute, you guys are thinking, depending on what the patient is, you were thinking outside of the lungs. So cardiac issues, she's having chest pain. You can't forget about the heart. You were thinking about, if it was more long-term, you might think a little more about the family history too, in terms of like autoimmune disorders, like does she have sarcoidosis that's new onset or something like that? Has she started a new medication around a certain time that may be causing a cough? There are some medications like lisinopril or certain ACE inhibitors that are for blood pressure and other medicines that can sometimes cause a cough that is dry. You want to think about things like what helps it or what makes it worse. So she mentioned that she was short of breath. One big thing that you want to ask when you're having someone who's short of breath is, are you feeling more winded when you are doing different activities, like you're exerting yourself more, like dyspnea on exertion, or is it at rest? That is more concerning when it's at rest. It's concerning with both, but a little more when you can't even kind of catch your breath when you're sitting. Does anything help it? Like, did she try for this cough any over-the-counter cough medicines? Did she try any prescriptions? Has she recently gone to an urgent care and gotten probably some unnecessary antibiotics? Like, what has helped her? What is making it worse? Things about quality. So like, what does it feel like? Sometimes people will be very descriptive, and it's good to ask those open-ended questions because it'll help you differentiate between if it's sharp pain versus a pressure versus certain things that can help kind of quantify what's going on. Where is it? Like, is her pain moving? Is she having other things? She mentioned that she was having muscle aches. Where are the muscle aches? Are they diffuse? Because you could think about certain things like viral illnesses, COVID, the flu, or if it's more specific in a different area, like is she having muscle aches from coughing in her rib area or in her knees or somewhere different places, her calves. How bad is it? Because that can kind of, although it's subjective, it can make some people kind of move. This person is coming online with a cough and shortness of breath. That's 7 out of 10. Why is she coming online? And what does she think that she can get from here? Does she think that she just wants some medication? Does she need that nudge to say, okay, you probably need an exam? I know that someone mentioned that they would like to see some of her vital signs. Vitals are important and vitals are vital. So I like to say that with telemedicine, about 65-70% you can get a great history on and mostly treat. Like if someone's coming in with GERD, if they're not of a certain age where you're thinking of heart attacks, is with food and things like that, you can treat it. Someone comes in with certain knee pain, you can give them some recommendations. If it doesn't get better, they'll need to go inside for an assessment or maybe physical therapy, but you can start. But if someone is coming in with new onset chest pain, shortness of breath, cough, aches, you have no vital signs, they don't need to pass go. They need to go inside. So now we're at the point where we want to know about the things that you would do, because on the telemedicine visit, we strongly voice the concern and the limitations of the lack of exam and encourage the patient to go be seen. So Cardi decided to listen, to go be seen ASAP. So she went to the emergency department. So she's gotten there. What things would you like to, they asked the same questions, came to the same kind of murky confusion of no diagnosis. So what things would you like to know about their exam and other things, or what tests would you order and stuff like that?
So someone just said an x-ray and a spirometer. There's a couple of people saying an EKG potentially, blood pressure, oxygen tests, vitals. Someone said ECG, troponin, a rainbow set of vials. And of course, someone said a physical exam. Definitely listen to her heart and lungs.
Yeah, those are all great things. And I think she would get every last one of those in an emergency department, which is why she was sent there. So just to go through a few things why and what we may be thinking. So if someone is coming in with chest pain that is new onset, not improving, you should get an EKG. There's such thing as an NSTEMI versus a STEMI. So there may be some changes that are not seen on your EKG. So therefore, you need to use your history, your physical exam, as well as certain labs like the troponins that someone mentioned, because that is an enzyme that comes off the heart when there is damage over a certain amount of hours, and you'll trend it to make sure that the person is not having any cardiac issues. Someone else mentioned vital signs, certain things that you would want to know. If this person has a fever, they may be more likely to have an infection. If the person, although there are some things where you may have a fever and not an infection, so because there's inflammation. Does this person have any signs she's coughing? Is she tachypnic? Is her respiratory rate very fast? Hers it was about, I think, like 22. Is she hypoxic? So of course we're thinking about COVID, like is her oxygen level very low? Is her, what is she hypoxic? Is she tachycardic? Is her heart racing and trying to kind of do its job because it's under a lot of stress? What is her blood pressure? Is it very high? Would that give us a higher chance of having something like a hypertensive emergency or an acute coronary syndrome? Is it very low? Is she hypotensive? Is she almost needing to get fluids or to go to the ICU if her things are too low? So there are a lot of things that the physical exam can give us as just from vitals alone. When you get to the exam, is her heart regular? Like, does she have an arrhythmia? Does she have any swelling in her lower extremity? She was having muscle aches. Is there something there that might suggest something else going on, like fluid retention? Or does she have pain in her calves or swelling in her legs or a rash signifying something else going on? Other things you would think about, someone mentioned imaging. So starting with an x-ray is good. A lot of people have been mentioning asthma, that it could be an asthma exacerbation, less likely if she had no medical conditions, but you could think about something else like in the family of asthma without asthma, like a reactive airway disease or a bronchitis that's typically triggered by a virus. If she were a smoker, although she's 28, it's very unlikely unless there was a genetic component, because some people can get emphysema or COPD without having a history of smoking. So we're things like that you could see. Is there any fluid on her lungs in the x-ray? So we'll get to a little bit of, I wasn't as extensive on this document, but she was tachypnic. She didn't really have a fever. What is the temperature that is classified as a fever? I'll ask you guys.
So we're getting a variety of responses. Some people are saying 100.4. Some people just said generally over 100. We have a couple of 99.1s. Someone said greater than 98.6, but the majority of people have said something in the hundreds.
Yes. So this is a great question that you guys should write down now, because you'll get asked it a lot, especially on your pediatric rotations or your internal medicine and when you're talking to your patients. So a fever is classified as 100.4. Some pediatricians kind of go back and forth on if it's 100.5 versus 100.4, but it's typically generally accepted to be 100.4 by the Infectious Disease Society of America and a lot of other societies. And that makes a big difference. So a lot of patients will come in and they'll be like, I'm febrile, and you're like, no, you're not. So it definitely, knowing what the temperature is important. Her heart rate was high at 115. Her respiratory rate was 22. She was diaphoretic. She had retractions, kind of where the strap muscles around your neck are kind of going up and down, and it looks like they're working hard to breathe. She had some tenderness to palpation on her right calf, and when you listen to her lungs, there were it sounded wet, like some rails or crackles kind of in her right side. So from there, we've been talking about the differential, so I'll just go to the next slide. So here are some things, and you covered most of them, that you would think of. So of course, COVID being COVID, lungs, all that kind of stuff. You got to have that on the differential. Asthma, reactive airway disease, pleural effusion, where there is fluid on the lungs, acute coronary syndrome, pneumonia, if there was some type of bacterial infection. Sometimes you can have viral pneumonias as well. Pneumothorax, you probably wouldn't have any lung sounds on that part. Acute heart failure, acute valvular dysfunction, aortic dissection, cardiac tamponade, as well as a lot of the other things that you guys said. Is there anything else that you guys are thinking of now?
So I guess as we wait for responses to come back, someone asked, realistically, would a COVID test be the first thing done even before a first physical or even before a full physical exam?
Probably not how she's presenting with the 7 out of 10 chest pain. So honestly, they would do the EKG and the troponins. COVID would be a part of the whole thing, of course. They probably get imaging because everything is kind of happening at the same time. But COVID would be the first thing. You would not let them leave without a COVID test. Although some take a couple days versus rapid that can take a couple hours, but the rapid is not always as accurate. It's about 30% in terms of false negatives.
Great, thank you for clearing that up for us. There hasn't been anything in the public chat yet, but there's a couple of private messages saying potentially pneumonia. Someone else messaged and said, someone said if there are crackle sounds, I'm thinking fluid in the lungs, so either pneumonia or acute heart failure.
Those are all great things. And those are some things I would think. So we've already talked about what we would order. One thing that kind of stood back, so crackles was kind of a red herring. There's, in some cases, this can be present in this disease, but it's plus or minus if you can actually hear it. The actual thing that stood out in this case, I think, was, I don't know if I mentioned it, but her pain on tenderness and palpation and on her calf. This person is a young person, no medical history, female, chest pain, shortness of breath. You have to think about a PE with her. So she had a PE.
Someone in the chat just said DVT as you were saying that.
So so the DVT started and it went up to her lungs and caused an embolism there. Do you guys know what treatment you get for a PE?
People are saying blood thinners in the chat.
Absolutely. That is correct. So we'll just look at this little, I don't know how easy it is to read, but this kind of diagram algorithm talking about how to treat PEs. So in this case, Cardi's young, she's healthy, she's doing well. We're thinking that her cause is her birth control pills because she just had the baby. She's not ready to have any more. She's ready to get over COVID and go on tour and go to the club. So she was on birth control. It led to this PE. She was not hemodynamically unstable. Like her blood pressure wasn't so very low or very high. She was able to breathe, all those kind of things. So she didn't need to go to the ICU. So we were able to treat her pain and then start her on low molecular weight heparin or Lovenox, where she can get some injections for 5 days and be treated as an outpatient after monitoring. So you usually, if a patient came in, they had a DVT, a PE, like you could usually do a Doppler ultrasound, which I also did not mention, to kind of look and find the DVT as well. There may be some remnants. And then you would do a CT scan to look for the imaging on the lungs to see the PE, the embolus. They're traditionally, back in the day, some people, and there's a lot of criteria and a lot of dispute, would recommend sometimes like doing a D-dimer test that looks for inflammation in certain things and with certain risk factors. When you look into it, I'm not going to go into that on here, but the Wells criteria it can kind of tell you whether or not it's a lower or higher risk of getting a DVT. One reason that we move away from ordering D-dimers is because they're very non-specific. When there's inflammation in the body, whether or not it's from a virus, if they just took some certain medicine, if they did certain things, it may be abnormal. So it's kind of like ordering the test to wait to order the VQ scan that they do sometimes to show an area where there is an embolus, when in actuality, you're just going to order a CT scan afterwards to confirm. So she got her heparin, she went home, and typically because she had this new onset diagnosis, she would probably be on anticoagulation like warfarin for 3 months. Now, if she had another event, she may need to be on it lifelong. We're thinking since she was on birth control, the estrogen component was kind of a factor, so she would not be able to get any more estrogen-based medications. So you would think about giving her something like a IUD or a Nexplanon if she wanted to prevent contraception, like for contraception. If a patient had other higher risk PEs, like if it was very large, what they call like submassive or massive, if the person looked unwell, if they had a large clot burden, if they did the echo, which they usually do after you have a PE, where they look and see how your heart is functioning, if it's pumping well enough, or if there were elevated parts on their labs, they may get anticoagulation, but they may also have to get other things to kind of like clot busters to break it down, like TPA, depending on where it is, or lysis. And in extreme cases, sometimes they have to get it surgically removed. And then there's newer technology out there called catheter-directed lysis, where they use a catheter and they directly inject the area to kind of with like a clot buster to decrease the clot burden. And then they might need to be in a high decision unit or a respiratory unit to be monitored. And then for massive ones where there's ongoing hypotension and the patient just isn't doing well, they may have a lower bleeding risk, so they might need to get a surgery or just get TPA. But if they have a higher bleeding risk, you want to avoid the TPA, which decreases their risk of bleeding. And you might want to do that catheter-directed lysis and monitor them in the ICU. So in summary, these are some key points of things you might look at for this case. So clinical features. So she had dyspnea, tachypnea, her respiratory rate was over 20, tachycardia, hers I think was 115, some pleuritic chest pain, symptoms of a DVT. This person, not everyone has hypotension, but this person had hypotension. We caught cardies early enough where she didn't have that. Some people it's plus or minus if you can have a fever. In some cases, there is some hemoptysis. So things you would think about with hemoptysis and a cough, you would think about PE, you think about TB, and some other things. She may have syncope where they lose consciousness. Risk factors, people pointed out like long sedentary travel, if she had some lung trauma, if she had some surgery, if there was a recent birth, if she had a current or a previous TB, or if they're on oral contraceptives. So she kind of had two because she had the DVT and she had this. Investigating, so we all looked at the EKG. Hers was normal, but there can be changes on the EKG with a PE. Chest x-ray. I'm not a fan of the D-dimer, but if you're taking a test, they're going to ask you to do a D-dimer. And in real life, you'll get the CT scan or the VQ scan. And then you'll give that low molecular weight heparin. You'll continue that for 5 days, and then you'll probably do warfarin for about 3 months. So that concludes my case. I just wanted to tell you guys that we started talking about telemedicine and how COVID affects everything, but yes, COVID is the great imitator, but don't be afraid to just think critically and remember your differential diagnoses and not just say everything is COVID. I have witnessed a lot of people, especially during the beginning of the pandemic, where people are coming in with chest pain, shortness of breath, that kind of stuff, and you're thinking it's COVID, and you're like, all right, do you have a pulse ox at home and certain things like that? But sometimes time is important, especially when there are clots, that if you think that someone needs a physical exam, it's okay to recommend that they go in. And is telemedicine the future? We will see, but it looks like it is. So in summary, telemedicine is not new, but COVID has changed the landscape of it with the world. There are some limitations to use because sometimes that 30% people do need to be seen, and don't let COVID cloud your diagnosis. So we can leave the rest of the time for questions.
Thank you so much, Dr. DeRouen. This was awesome. Someone just said they love the diagrams, and we completely agree. It was really easy to understand and follow. So thank you so much for that.
Oh, you're welcome. And I'm happy to I guess share this if you guys want it. I can email it to you.
Yeah, that would be awesome. And this will also be up on our YouTube later. So if anyone wants to go back, they can also do that as well. We'll go ahead and ask some of the questions that were asked. So you did state that you believe telemedicine is the future, but some people are asking, what capacity do you think it will be in after COVID? Do you think that people will still want to use it? And then, yeah, I guess just kind of like your thoughts on that.
Yeah, that's a really great question. And I think it's something that everyone is asking. There's a lot of investments going on into telemedicine and a lot of
I think you got muted on accident. Sorry.
Can you guys hear me now?
Yes.
Okay. So it's kind of figuring out, I think it will be around. It's just kind of figuring out in what capacity and also how we can leverage the technology to expand to other places. So I think there needs to be a lot of connectivity in terms of with primary care so that there can be shared medical records and labs will not be duplicated. And there can be an avenue for patients to have a way where they don't utilize this as their complete and only healthcare provider, because then we may utilize different resources in the wrong capacity, like overutilizing urgent care if they needed to be seen or something, but kind of using telemedicine as an adjunct, I think will be the future.
Great, thank you so much for answering that question for us. So kind of going back to the case study that you presented, there were a couple of people asking if you could talk about someone who would get a PE or a DVT, but had a high bleeding risk or was already on blood thinners, what that treatment would look like for them.
Okay, so when people have high bleeding risk, it's kind of like the risk and benefit, figuring out where that is. So traditionally, even before they had a lot of anticoagulants, we have the newer agents and things that are not needed to. Warfarin has a long history of the different types of diets you need to take and how you have to monitor it all the time, just kind of figure out the dose adjustments. And then if there are issues, you have to give them medicines like vitamin K and things to counteract that. So we have a lot of newer agents, but for people who have high bleeding risks, they can get something called an IVC filter. And it's a surgically placed, and it kind of is put in your veins and it kind of catches the stuff.
Great, thank you for answering that, clarifying that for us. There was a question earlier just talking about more of the logistics of telemedicine and knowing that it's something new and maybe in comparison to pre-COVID to now. Do you have any idea how insurance companies are handling telemedicine visits? Because that's very different and they used to not be able to cover all of them.
So that's a very hot topic. I would definitely suggest that you guys look on some of the healthcare technology websites and things where they're talking about that. They're also talking a lot about it at the AMA. But coverage is important. They weren't covering a lot of it before, but now with Medicare expansion, they have been. It's up in the air as to how long the coverage will last. So there will need to be some advocacy in terms of that. Different companies have different models. So a lot of the hospital systems and traditional brick and mortar offices are utilizing insurance, but some companies are charging employers to keep people well. Other companies are letting the consumers buy a package, and then you'll have to go through your insurance for different stuff. So it's kind of which one is better type model. I don't think there is any particular thing there. In brick and mortar, there are direct to consumer practices, kind of, they call them DPC, direct primary care practices, popping up, where they don't necessarily take insurance, but they kind of help find bundles and stuff for you. So it may offer some more access to people who don't have insurance, like underinsured people, but in the long run, they're going to have insurance on board.
For sure. Thank you for giving us that insight, and hopefully it will be covered in the future. We'll see. Someone was asking, kind of going back to talking about PE, we mentioned birth control being, the cause of the blood clot. So how often is that seen to be, the causation, and, how long that you're on birth control? Does that have a correlation to the intensity or severity of it?
That's a great question. I don't know the percent, the rate that it happens. I will say in my time, I have seen it happen from a few patients that I've started people on. Unfortunately, that's it's a very well-known risk of increased estrogen. It increases clot burden. You're supposed to counsel the patients on that before they take it. It increases with certain risks like age, being greater than 35. If you're a smoker, if you're both, I would not prescribe that to anyone who's over 35 and smoking. It also increases with other risk factors like family history, if they've had clots before, and all of those kind of things, if they have migraines with aura. There is a great app through the CDC where it looks at, I forgot the name, but if you guys look up the medical eligibility criteria for contraceptives or something like that, it will tell you the different types of contraceptives, and you can plug in certain risk factors to see which categories of recommendations it falls under. For certain people that have hypertension, and they're not recommended to be on combined oral contraceptives, or like we said, the different things. So it'll go into a lot to kind of figure out people's risk.
Great, thank you so much for answering that question for us. We'll go ahead and do one more question before we do a little wrap-up question. So someone was asking if you could talk a little bit about the equity concerns that you have seen or that you expect to see with telehealth and access to technology.
That's a great question, and one of my favorite things to talk about. There's a lot of inequity in healthcare. There are a lot of health disparities. It is something that is well known. It's ingrained in the American healthcare system over time. There have been so many experimentations, not only the common things like the Tuskegee experiments, but many, many, many more. So telemedicine and COVID has kind of highlighted where we are in terms of the inequities. African American people are dying 2.8 times more than the rest of the country for COVID, and they have the same resources. They are not getting vaccinated at the same rate. I think I saw something today where I think 3% of the country of all the people who are vaccinated are Black. So we have a ways to go. And in terms of telemedicine, I think that they also have a way to go. So where there are disparities, some people may live in environments where they may not have the resources to utilize the certain apps or the phones, or some people may not have the financial capabilities where it's going through certain employers. Some people may not have all of the things that they need to in order to do well, because a lot of telemedicine organizations at this point are kind of self-selected by people who are tech savvy. And so is taking out people with disabilities, people who may need to use sign language or are maybe deaf or things like that. It's taking out people with higher level or more intense healthcare issues. And then in terms of just like allowing for different things to be kind of noticed, as we're seeing in healthcare in general, there is a lot of inequity in terms of even having the foresight for technology for things. So with certain skin infections or different dermatologic diseases, they look different on different skin complexions. So if you don't have people who are developing these apps in the room kind of making these decisions, then people of color will be an afterthought. So there are a lot of times where I think that we need to definitely advocate for there to be more diversity in the leadership of these organizations, on the board of directors, in the venture capitalist meetings and stuff like that, so that they can look at it with an equity lens.
Thank you so much for answering that question. It's a super, I mean, we could talk about, there's been a whole session on just that. So thank you for answering that as succinctly as you could. That's super important to think about. So thank you so much for giving us your thoughts on that. I guess the last question that we have for you as we wrap up is, what last piece of advice would you leave us pre-med students with, post-bac, undergrads, as we're navigating this tough time of COVID?
First of all, I want to commend all of you guys, because I cannot imagine being a pre-med at this point, where there's such a decrease in not only interactions and opportunities to shadow, but also to commune with your colleagues. Because this is an experience where it's universal when you're trying to apply and study and doing all of those kind of things, but that support system is very important. So for you guys, I would just say, just keep on innovating different ways to make human connections and figure out ways to get to where you want to be, utilizing things like this resource, connecting with your classmates on like Slack, figuring out different like podcasts and different things that can help you kind of learn the information and things. I would say also, don't be afraid to reach out for help. It can be very isolating during these times, both I'm sure academically, where things are changing and you might not be in the best study area right now, or your family members may be sick, and all of those kinds of things, and trying to figure out how to dedicate your time professionally, but also as a human being, realizing that you are a human being. Like, it's okay to slip up. I think everyone has mistakes, especially with you guys studying during a pandemic. So it's okay to fail. It's okay to try again, as long as you just try again. And I would also just say, like, be authentically yourself, stand up for what you believe in, learn how to advocate for yourself now, because those skills will help you advocate for your patients in the future. And just keep shining. Like, don't let anybody dim your light because it's shining in their eyes. Like, there's enough piece of the pie for everyone. So when you guys do get together, like, it shouldn't be a competition. Like, one person may be good at cardiology while the other good person's good at pulmonology. Like, put your notes together. Like, don't be a gunner. Like, it's room for everyone. So you guys are smart enough to make it. You will, and I wish you guys the best of luck.
Thank you so much. We all needed to hear this, especially kind of towards the end of the week when we're all struggling. So thank you for that. We put Dr. DeRouen's Instagram and her podcast in the chat, and thank you so much for joining us. We'll definitely keep in touch, and we hope you have a great rest of your day.
Absolutely. I hope you guys have a great time too. Thanks for having me.
Thank you. Of course. Bye.
Thank you.
And then for anyone who has any questions,